take it from here.
Okay, so this semester I wanted to do some research into how eating disorders impact us globally. I knew that they were a pretty big problem in the US, but I had a feeling they were a bigger problem on a global scale as well. And I've really been passionate about holistic care and mental health for a long time. And the research that I did was pretty amazing in an awe-inspiring and a wow, we really need to do something about this kind of way. And so I researched a few different countries and some really vulnerable populations that need more attention paid to them. And so this presentation kind of looks at the countries and the populations and what causes eating disorders and the different roles that they play in different countries and all of the different aspects that happen when you have eating disorders going around in different parts of the world. So that's what I'm going to kind of address in this presentation. So I wanted to start by reading this to you guys. This is a poem about what it's like to have an eating disorder. So this is called Old Friends. Some days the weight of it gets to be too much. Some days the vastness is just too great. Some days I wish for a visit from my old friend. My old friend, she lets herself in through the back door. I did not invite her, but I had a feeling she was going to drop by. My old friend, she embraces me like no time has passed. My weary spirit captivated by her charm, my old friend. My old friend, oh, the sweet comfort and love she brings. I curl up in her empty promises and take shelter in her familiarity and lies. My old friend, she never leaves me. Her rules protect me from all the trauma. Her obsessive rules make me strong. Her denial makes me numb, my old friend. Some days the weight of it gets to be too much. Some days the vastness is too great. Today I welcomed my old friend anorexia back in with open arms. My soul died today, a death without a funeral. So I just wanted to read that because a lot of people don't quite understand the depth that eating disorders play mentally in someone's brain, and that it really is an addiction like any other addiction, that someone is not choosing this, but it really invades your brain in a way that takes over someone's mind and makes it impossible for them to break out of a lot of times. So I just wanted to kind of bring that home before I get into the presentation. So I wanted to start out with myths or facts, the truth about eating disorders. So to start out, there's a lot of myths about eating disorders that people have. So a lot of common ones are that eating disorders are a choice, phases, cries for attention. They're caused by bad parenting. They're diseases that only affect white or middle class males. But all those are not true. The facts are that eating disorders are biopsychosocial illnesses. They are up to 60% genetically linked. They affect both men and women, and they can happen to anyone, any race, any time of life. Anyone can develop an eating disorder. There are parenting styles that can exacerbate someone who has factors that could lead to an eating disorder, but solely bad parenting is not going to be the cause of an eating disorder. So then, what are eating disorders exactly? Well, in short, eating disorders are serious and sometimes, unfortunately, fatal mental illnesses. They're associated with pretty severe disturbances in a person's eating behaviors and the thoughts and emotions that go along with it. It's not just the food, it's really the thoughts and emotions. And signs and symptoms include preoccupation with food, body, weight, shape, and exercise. And the rest of these, like social activities, isolation, anxiety, and depression, I'll be addressing more with the specific disorders that I'll go into in the next slides. So of these individuals that I have on here, who would you suspect has an eating disorder? So select one, select all, select several. Who do you think has an eating disorder of these?
Feel free to start typing stuff in the chat box. Getting a lot of D and F, A and F.
Okay.
We got one person who said all.
Very interesting.
H.
Okay. So I can understand where you guys would come from with those. However, none of them, all of them, we don't know, because health at every size, illness at every size, body shape and size are extremely poor indicators of illness and wellness. Unfortunately, if we just look at an individual, unless they have a BMI of 12 or a BMI of 100, you really cannot look at an individual's body with knowing nothing else about them and say, this person has an illness or this person is well, because knowing nothing else about their life or their lifestyle or their food choices or their behaviors, you really don't know if they have a disorder. So that person could be extremely healthy. We just don't know. So judging someone by how they look to say that they have an eating disorder is actually probably one of the biggest mistakes that healthcare professionals make. So the first eating disorder I'm going to talk about is anorexia nervosa, which is probably one of the most typical ones people think about when they think about eating disorders. And this is when an individual purposely restricts calorie intake and they have extremely low body weights. They also suffer from very distorted body images, like you'll see in the lower left-hand corner of an individual weighing herself, but she's very thin and she sees herself as a very large individual. They usually compensate with excessive exercise, with the lack of calorie intake as well. And very common health effects are low blood pressure, bradycardia, and the brain fog and inability to think, along with imbalanced electrolytes. And a big thing with anorexia as well in regard to pregnancy is usually a woman's periods stop and they have higher risk for miscarriage, low birth weight, and very high risk of postpartum depression if they are pregnant at the time of anorexia. Another common one is bulimia nervosa, and this is characterized by episodes of binge eating and purging. Binge eating is not you're extremely hungry, you ate a really big pasta dinner. This is someone sitting down and eating 2, 5, 10,000 calories, and then they're making up for it by excessive exercise or self-induced vomiting, laxatives, things like that. And they can be underweight, healthy weight, or overweight. And then if you look at the graphic in the lower left-hand corner, this is the cycle of binge purge that people get stuck in. And it is a very addictive cycle because they start in the top with the diet. This leads to them feeling in control. Like most people would say, yes, I'm on a diet, I'm in control of this, but then they feel hungry. This leads to anxiety, which causes them to eat a normal amount of food, but they feel guilty for eating, which makes them feel out of control, which leads to a binge, which makes them feel numb. Then they purge to have feelings. They feel redeemed because they purge. They're back on their diet again. Then they feel in control, but then they feel hungry. The cycle repeats. That's why people get stuck in this binge purge cycle. And because of that, then they have improper volume, low BP, sudden death from purging, things like that. A lot of times they have tooth erosion. That's one of the things they cannot hide from their families because dentists catch that a lot. So that's a huge sign of bulimia nervosa is tooth erosion caught by dentists. This disorder is one of the newest disorders that has been classified in the DSM-5 that's used by psychiatrists, called avoidant restrictive food intake disorder. And this is most commonly seen in young children and adolescents. And this has nothing to do with food in regard to being fearful of being fat. This has to do a lot with sensory perception and negative experiences due to like autism and textures and tastes and very negative experiences with food early in life. So a lot of these kids will fall off their growth curves. They will not gain the expected amount of weight. And they usually have very poor growth, lack of appropriate vitamins, minerals, and some of them will end up dependent on feeding tubes and TPN because they have such disinterest and avoidance of certain foods. This can be seen in adults as well who have not been diagnosed with autism or sensory processing disorders, but it's most commonly seen in children and adolescents. So this again is about ARFID. This is much, much more than picky eating. This used to be considered just extreme picky eating. It is not. The sensory factors and fear of consequences and lack of interest is like the trifecta of ARFID. Appearance, color, texture, smell, all of these are amplified in sensory processing disorders. The lack of interest, a lot of times when kids are going through growth spurts, they're very interested in food, but a lot of children go through periods where they're less interested in eating when they are not, like during toddler and preschool times. They're very much have little snacks, things like that. But if parents force their sensory sensitive children to eat when they are not in periods of extreme growth, they can develop these really negative relationships with food. And if that child already had a fear of consequences, like they had vomiting episodes, choking, or if they're in the imaginary stage and they swallowed a seed and someone told them now a watermelon is going to grow in their belly, they can develop these disorders. So it's really important not to be forcing these children to eat. And then if they do develop ARFID, to have them seek the appropriate treatment. And then the last disorder that I'm going to talk about is called other specified feeding and eating disorders. It's called,
Lucy, from the chat box. I think it was related to ARFID, and it said, which age does ARFID commonly start to occur at?
It's usually seen around the age of 4 to 6 that it starts getting diagnosed.
And I believe that in your research, you mentioned a lot of times that sometimes adults are diagnosed because in childhood they were just told, oh, you're an extremely picky eater, along the same lines that we didn't have diagnoses for sensory disorders many years ago as well.
Yes, a lot of kids around the ages of 4 to 6 is when we start seeing this ARFID diagnosis. And then there are adults who were told all these years ago, there are no diagnoses. They did not get diagnosed with autism or sensory processing disorder or anything like that, and were just had the label of very picky eater slapped on them. They now fit the criteria for ARFID. And have sought treatment for ARFID now because that small group of individuals are the adults that are then diagnosed with ARFID because they had much more than picky eating.
Couple more questions related to what you just mentioned, actually. Judine asked, is ARFID reversible? And Anna Maria asked, what does treatment generally look like?
Yes, ARFID is reversible. It involves a lot of sensory autism treatment with cognitive behavioral therapy along with eating disorder treatment. It has to be joined together with those treatments. It cannot just solely be eating disorder treatment and solely autistic treatment or sensory perception treatment, because the two separately don't work individually. They have to be joined together, and you need usually teams. A lot of times they're at specific children's hospitals because they're so often seen in children. And then, I'm sorry, what was the other question?
You answered it exactly. Is it reversible, and how do you treat it? I think something else that you mentioned, sometimes people ask about medications. Sometimes periactin and appetite stimulants are also used.
Yes.
Yeah.
Yes. And depending on the child, sometimes gastric emptying medications will be used as well if they have slow motility, which some of these children do.
Thanks a lot.
Mm-hmm. So then other specified feeding and eating disorders, it's called OSFED. And so this one is a little bit tricky. So individuals who do not meet all criteria in the DSM-5 for another disorder are diagnosed with OSFED. So this can be difficult mentally for some people to accept because they feel like they aren't being good enough at their disorder, which can be difficult for people looking on the outside in to understand. But if someone who is displaying symptoms of anorexia nervosa, all the restricting, over-exercising, everything, but doesn't quite meet the lower than ideal body weight requirement for anorexia, according to the DSM-5, they'll be diagnosed with OSFED. Or if someone with bulimia nervosa tendencies is not purging 3 to 5 times per week, having 2 to 3 binges per week, and every criteria that needs to be met to make that diagnosis, they'll be diagnosed with OSFED as well. So sometimes it can be extremely triggering for that individual because they feel like they're not good enough to seek treatment. So it can be difficult for that individual, that family insurance coverage, which is honestly why they made this diagnosis, so insurance would still cover treatment. There is another diagnosis also that OSFED covers, specifically diabulimia, which is specifically for type 1 diabetics. And it's the deliberate restriction, mismanagement, or omission of insulin for type 1 diabetics in order to lose weight. And it is extremely effective. However, it's extremely dangerous as well. If a type 1 diabetic eats and omits their insulin, we all know that that person cannot use that energy because they do not have the insulin in order to let that energy into the cell. So the body then is forced to obtain the energy from fat and muscle stores. This results in very rapid weight loss, but that person will be showing frequent DKA, hyperglycemia, high HbA1cs because their glucose is going to be completely out of control. And unfortunately, very, very nasty side effects like stroke, heart attack, long-term vessel damage. So it's very scary. The side effects are very severe when this is not caught and treated. A lot of type 1 diabetic adolescent girls suffer from this because you take someone who has never looked at nutrition in their life and you tell them, you now have to start counting carbs immediately. You can never not look at another label in your life. And now all of a sudden that person has to be hyper-focused on food for the rest of their life. It's a very big problem that dietitians are not addressing at this point, and that needs to change because you're taking someone who has not ordinarily done that, or just like with food allergies, you're doing the same thing, and it's a problem that has not yet been addressed. So those type of things can lead to these types of disorders where they're hyper-focused on food.
Question from Chelsea asking about OSFED. Can it be body image based was the question.
What about body image?
Can OSFED be based on body image? I think the question's asking more about, is it related to the way the person feels about the way their body looks?
Any of the disorders can be minus RFED.
Got it.
Yes. Any of the disorders are going to have a piece of body dissatisfaction. Solely based on body dissatisfaction, no. But generally that is a piece of it because the way that people are expressing their dissatisfaction is through these behaviors to have some sort of control, although it's not real control. It is their version of perceived control that they are going to change something about themselves.
Thank you.
So now that we've talked about those disorders, I'd like to address some of the outcomes that we're seeing. So for individuals with anorexia, unfortunately, without treatment, 20% of those individuals will die. So if I have a room full of 10 girls or guys with anorexia, 2 out of those 10 people will die without treatment. No questions asked, which is extremely hard to think about, but it's the truth. That is what is happening. It's a very difficult disease to treat, and that's where we're at right now. Out of all of the eating disorders I talked about, 1/3 of patients will never recover and have the illness for life. 1/3 of the patients will achieve full recovery, and 1/3 of the patients will waffle between relapse and recovery for life. And I want to talk a little bit about what that last one means. These diseases are very sneaky. So if people think about coping skills and what you do when you're stressed, maybe you punch a pillow, maybe you go out for a run, maybe, whatever you do, But a lot of times this is what these people do to control their stress. So if you think about a really stressful time in your life, even if you've been in recovery from an eating disorder for 5 years and you have a massively stressful time in your life, even if that person has been in solid recovery, this might be what their brain flips to. So they've had a great run of recovery, but they go through some traumatic event like losing a parent or losing a job, and they start binging and purging again. That's waffling between relapse and recovery. Choosing recovery is something they have to do every single day for the rest of their life. And it's not to say that they can't go back to recovery, but that's someone who is waffling between relapse and recovery for life then, if they're going through periods of time where they're in recovery and then relapsing and then in recovery and relapsing. So that's why there's so few people who achieve full recovery and stay in recovery for life.
Lucy, you're getting a lot of virtual head nods. I'm getting so true and great point.
Okay. So then we also have to deal with the economic impact of these eating disorders. So when people are able to seek treatment, it is extremely expensive. So inpatient treatment is generally 2 to 4 weeks in length, and on average is $2,000 per day. And this is pretty universal. So in the US and in the UK and other countries that I'll get to, residential treatment is generally 90 days in length and on average costs $1,000 per day. So residential treatment is where you go somewhere and you live basically in a center, like an apartment complex, if you will, and you basically relearn how to function without an eating disorder and deal with all the stress of life, not using eating disorder behaviors. Inpatient treatment is like a special hospital just to deal with eating disorders. So, but if you think about it, $2,000 times a month of treatment, 90 days times $1,000, people are remortgaging their homes, taking out loans, asking their relatives. This is massive amounts of money. And a lot of times, one go at treatment isn't enough. The average length that it takes someone to recover from an eating disorder is 7 years for one go. It's a very long time, and that's with repeated treatment, and that's with repeated relapse. So that's an extremely large amount of money. And to top that off, individuals with eating disorders compared to their healthy counterparts make less money, are less likely to be employed with regular work. Most of them have additional comorbidities, and they make less money per year. So those statistics for employment, most of these people, I'm just going to talk about with the additional comorbidities, because over 50% of people with eating disorders have additional comorbidities: anxiety, depression, diabetes, like we talked about, other chronic health problems. Any of those are additional comorbidities. So with comorbidities, they are 59% less likely to have regular work. They're between, they will make $2,000 to $7,000 less for their annual income. And with an additional comorbidity, they will make basically $20,000 to $35,000 less per year, but they will have all these additional costs. So they're massive drain on the economy, and they can't afford the treatment. So it's really a catch-22 of how do I even begin to pay for this and survive? So it's a really big problem that the entire world is seeing right now.
Lucy, we had a question about insurance coverage. Do insurance generally will only cover a portion of the treatment, or does it depend on where you live, that type of thing?
Insurance is very, very picky about what they will and will not cover. It depends on what kind of insurance you have. It depends on where you live. It depends on how sick you are, unfortunately. Some insurance companies will only cover the care someone really needs based on numbers. They will look at lab values. They will look at weight. They will look at, have they tried every least expensive option known to man first, even if they have medical doctors and psychiatrists and psychologists and therapists saying this person needs this aggressive form of treatment. It doesn't make any sense if someone goes in and has stage 1 breast cancer. They don't say, go home, wait till you have stage 4 and then we'll treat you. That's what they do with eating disorders. They say, you're not sick enough yet. We'll treat you when you're sicker. That's fine. We'll wait. You won't die yet. So we'll wait until you're knocking at death's door and then we'll treat you. So it's very backward compared to how we treat other like non-mental health diseases. It's a big problem in pretty much every way because it causes physical problems. And when they see the physical problems, like if you walk in with heart failure because of your eating disorder, they'll drop everything and reverse your heart failure. But as soon as your heart failure is reversed, you're out the door. So it's very backward to how we treat most other health problems. So there are states that, because of deaths of people with eating disorders, which I'll talk to later, to you guys later about some of the laws that have been put in place, because of those deaths, people have gone and fought and put laws in place, but it's not universal at all about what coverage is mandated.
So someone asked, do people drop out of treatment due to lack of funds ever?
All the time. It happens all the time.
Thanks, Lucy.
Mm-hmm. So these are the most recent global shares of the population with eating disorders as of 2017. So this is the global burden of disease. So, and these are massively reported under the statistics because these only show, this map only shows the clinically diagnosed anorexia and bulimia cases. And lots of people, let me be clear, walk around with clinically diagnosable eating disorders that have not been diagnosed because they cannot seek treatment. Their country doesn't have treatment. They don't have physicians who can diagnose. And as I just told you, there are way more diseases than just anorexia and bulimia nervosa. So in the United States, which I'll get to in a second, there are actually upwards of 30 million cases of eating disorders, but as this map shows, there's about 2 million that they show on this map. So, but even taking that into consideration, the countries that I looked at, this is a staggering number of eating disorders. So this shows the percentage of the population that is affected in these countries, which is obviously a big problem because it's in every country in the world. And this is not just rich white countries. This is absolutely everywhere, even in tribes in Africa. And that doesn't have to do with food disparities. This has to do with body image problems and maladaptive coping behaviors and things like that. So it's literally everywhere.
Lucy, there's an interesting discussion going on in the chat here asking why China and the US have such high numbers reported.
I looked at Japan, which I can get to a little later, but the quick version of that is the Asian culture is really homogenous and they want to all be the same. And their country wants to all be the same. And they have a beauty in tininess kind of mentality. Mm-hmm. And they have, the Japanese at least have a law about how big your waist can be. And they literally line them all up and measure them publicly. So obesity is not a thing there. You don't get to be. And if you do, you get publicly shamed and fined. So it's horrifying, and they are praised even if someone knows that person has a disease and an eating disorder. And it's better to be sick and small than large and healthy in these cultures because they want them all to be kind of cookie cutter rather than themselves. They want them all to look the same and act the same and be the same.
And there's also a comment in the chat box that's absolutely correct. China and the US also have larger populations, so proportionally yes, their numbers are going to be higher. But
that is also very true.
As Lucy said, yes, that was a lot of Asian culture she was discussing related to the question in the chat box if we were discussing China. It's actually a lot of Asian culture that we were discussing.
Yes.
And then there was a great question that's going to lead into your next points, Lucy, about if there are countries that are treating this better than the US.
Yes.
And we'll get to it.
Yes, we will get to it. I will get there. So this picture, don't really look at the numbers because there's a lot of numbers in there, a little bit confusing, but this just shows the total population in all the countries I looked at. But this is basically the disability adjusted life years, and we call them dailies. So this is per 100,000 individuals in the country, how many life years are lost to eating disorders. So overall healthy life years per 100,000 individuals are lost. So each of these colors just means the darker the color, the more life years lost. So overall, we're just losing tons of healthy life years in every country to eating disorders. It basically means we're losing so many healthy life years to eating disorders that we wouldn't otherwise if eating disorders were not a problem. So in this next slide, I broke it down and I added these all up, and total global disability adjusted life years for just anorexia and bulimia, we lost 5,756 years in 2017. And just to make it more relatable, you could earn 1,439 BSN degrees if you went to school full time. So we could do that, but just think about how much they could contribute to the world if they were not suffering from an eating disorder. So all of those people could be contributing, we don't even know what, in that amount of time. And they're not, because they're losing all those healthy life years to suffering from eating disorders. So when I looked at the big global picture, between the years of 2000 and 2018, there were 94 different studies highlighting the US, Europe, and Asia, and loads of other countries as well. But I focused on those since I did more research in those countries. And the major point that I want to make is that over the last 20 years, the rate of eating disorders has doubled from 3.5 to 7.8. And that is a really big problem that we are having. And every single country has unique factors that I'll get into that present challenges that perpetuate different parts of this biopsychosocial illness that's going to require special treatment in different parts of the world, because one model cannot fit all for this. But the fact that we've more than doubled in the past 20 years is extremely alarming. This is exponential growth and is not a small problem for us. This is something that needs to be addressed pretty rapidly, or we're going to have an even bigger problem on our hands. So I wanted to look then specifically how eating disorders are addressed around the world. And I was going to be looking at different countries, different NGOs, and how they operate in that country to address this problem, because obviously it's a big one, and I figured somebody has to be doing something about this. So who is it and what exactly do they do? So in the United States, there's over 30 million people who have eating disorders. And unfortunately, we're seeing that number grow on both ends of the spectrum, from not just the average like 15 to 24-year-old range anymore for 15 to 24-year-olds having eating disorders. We're seeing younger than 12-year-olds and older than 50-year-olds be admitted for pretty serious eating disorders. And very sadly, eating disorders have the highest mortality rate of any mental illness, and one person dies every single hour as a direct result of an eating disorder. So if you think about it, 24 people will die today because of eating disorders. 24 people are going to die today, and 24 people will never exist again because of eating disorders, just today. And if you think about that, that's why has no one been talking about that? Why don't we know about that? And why isn't there some great initiative to stop this? So that really, those numbers are shocking. And 70% of individuals don't even seek treatment due to the stigma, the misconceptions, the lack of education, and lack of diagnosis and proper access to care. And this is the United States we're talking about. So that's pretty scary.
Lucy, there was a question, have there been an increase in reported eating disorders in the male population?
Yes.
And they're asking if that's probably a lot more underreported or not.
It is a lot more underreported. There's about 20 million women and 10 million men currently. Out of the 30 million in the US, men are typically underreported due to the fact that it is more stigmatized in the male population, and they can't get as accurate of numbers in men because of underreporting, but those are the most accurate numbers we have currently.
And then there was a question, is the statistic of one person dying every hour in the US or around the world?
That's just in the US. So that's likely even greater.
And then somebody asked if the increase in numbers is related to media, and a lot of students were agreeing that probably increases in media access and things like that have led to a huge increase.
Media is definitely not helping, that's for sure. So the nonprofit governmental organization or NGO in the United States that operates is called NEDA, National Eating Disorder Association. And it's the largest NGO in the US. They have a very large social media presence, and they do Eating Disorder Awareness Week every year, which is in February. And they already have over 100 walks this year. And they have 35 states signed up to do awareness for these walks. And it usually gets close to 50 out of 50 states. They have crisis lines that you can call and text. Their website has instant messaging that has all different kinds of support groups and information for treatment centers and all different things like that. It serves the 20 million women and 10 million men that suffer in the United States. And they really want to put the information out there for prevention, cure, and access to better treatment, which is what their main focus is in the US. So then they have had several different initiatives, and this is one of their posters to try to help people understand what a big problem this is. So fashion models are not representative of what American women actually look like. They are thinner than 98% of all of us. So they're representing 2%, which doesn't really make a whole lot of sense. Why are they representing the 2% instead of the 98%? Because of this, 81% of 10-year-olds are afraid of being fat. So some people might say that doesn't mean a whole lot to me. So I can break that down for you. You have a classroom full of 4th graders. That's about 10-year-olds. 18 of 20 of them are terrified of being fat. That's what that means. So while they're trying to learn their math lessons, they're wondering if they should eat their sandwich at lunch because they're wondering if they're fat at 10 years old in a 4th grade classroom. That's what that means. And 50% of girls use unhealthy weight control behaviors. 50%, that's not that bad, right? Well, again, got 20 girls. All right, so put 20 random girls in a row. They sit down on a chair. I have a note card under every chair. Maybe you're the lucky one that says no behavior, or maybe you're the unlucky one that pulls your note card out and says you use laxatives, or you don't eat for 20 hours a day because you're fasting, or you overexercise, or you purge. Every other one of you is going to get one of those note cards because that's what 50% means. So when you think about it like that, that is an awful percentage. So these are numbers that absolutely have to change. So this is something that they're trying to address and bring home for people, that this is not an acceptable percentage to have, or even close to anything like that. So basically how NGOs are funded in the US are small NGOs fund other NGOs. So all of these organizational partners and sponsors are other small NGOs in the US funding NEDA. So these are other treatment centers, projects, and other people interested in stopping eating disorders funding NEDA. And these are people who have either recovered, gone through eating disorders, have had family members who have gone through eating disorders, died, unfortunately, things like that. So these people are not outsiders looking in, they are in the thick of it, which is important to know because they are not unaware of what is happening. They are really invested and passionate about the research and moving these programs forward because they've been through it and they know how significantly impactful these disorders and diseases are. So in the US, in contrast to other countries, the government really doesn't fund anything or get involved in the NGOs in the US. And then I looked at the United Kingdom as well. And in the United Kingdom, they basically have the same problems as the US. The US has heavy media influences. They have high academic standards. They have family control issues, dynamics, perfectionism, trauma, sports performance. That's a lot of what drives eating disorders in the US, along with loads of other things, but those are just a few. The United Kingdom is similar to the setup of the US. They have those problems as well. That drives a lot of it. About 5% of the population in the UK struggle with eating disorders. Very common to have anorexia, bulimia, or OSFED. And eating disorders cost about 1.55 billion US dollars per year in the United Kingdom. So that is a huge economic impact. And they have the NHS. So that is costing a lot of money for their health system. And the NGO that operates in the UK is called Beat Eating Disorders. And Beat is functioning to tackle the crisis basically of the lack of information that is available to the public and the community and all of the healthcare professionals that treat everyone. And so their main function is to inform, and that goes everywhere from healthcare workers to teachers to friends, parents. Everyone needs to know about eating disorders, just like they know the symptoms of a stroke. Every teacher needs to be able to ask the right questions. Every doctor needs to be able to refer people to the right treatment. Every parent needs to be equipped with the skills to know what to do if their loved one has an eating disorder. And the general public needs to be aware of eating disorder symptoms and be able to get someone help. So that's their main mission right now, to be able to equip everyone with basic information so that these people can get the help that they really need. So this is one of their public health everyday language posters. So obviously some of these words we are not super familiar with because they're in the UK, but lips, flips, hips, kips, nips, and skips. So this is everyday language in the UK. So for lips, are they obsessing about food? Flips, behavioral changes. Hips, are they having distorted beliefs about their body? Kips, are they often tired and struggling to concentrate? Nips, are they disappearing to the toilet after meals? And skips, are they starting to exercise excessively? So it's a poster that's really easy for people to see. It's catchy, it's fun, but it also is very informative about if someone is having any of these symptoms together in triplet and quadruplet, maybe they're experiencing the beginning of an eating disorder and you can get them help. So this is equipping the public with basic knowledge to know that if seen together, these things could really be a problem, and here's how to help someone who might be suffering from an eating disorder. Beat is located in Norwich, and in contrast to the US, they do work with the NHS, and they are able to get more funding, and some of these, like Ori Opiant and Elysium Healthcare, are also funded by the NHS, so they are able to access more research. So while some of these are small NGOs and charities that individuals have started, they do have more access to funds than the US does in regard to the government, because they are more willing to work with the government, and the government's more willing to work with the NGOs.
Lucy, you mentioned the NHS, that's the National Health Service, so like the public health department in England?
Yes.
Great, thanks.
So the UK government actually worked with Beat's NGO for a naloxone phase 2 trial for bulimia nervosa in 2019. So Opiant was the company that did it, and they wanted to test to see if intranasal naloxone would actually help to treat some of the very early stages of that binge purge cycle that I showed you guys earlier. And the thing with bulimia is that food works on those opioid receptors that we have in our brains to activate the pleasure and like tastiness that we get from eating sweet and fatty foods a lot of times, which is what people binge and purge on. And so in a phase 1 trial, they had found some promising results that if they had adjusted the dose, not like for if you're bringing someone back who has overdosed, but if they adjusted it, they could get some good results. Unfortunately, the trial did not pass phase 2. However, they were able to get some really beneficial medical data for the possible medical treatment of bulimia and eating disorders for the future. So this shows too how having governmental support in your NGO can really push some of this treatment forward. And they learned a lot about the medical functionality of bulimia in the brain. Next, I looked at Latin and South America, and this was very interesting because a lot of different things occur in Latin and South America. A lot of these people associate beauty with curvier body types. And so while they do suffer from eating disorders, they suffer more from bulimia nervosa and binge eating disorder, which I didn't touch on, but binge eating disorder is similar to bulimia. In the binging, there is just no compensatory purging behavior. So a lot of times these people suffer from clinical morbid obesity. Anorexia is seen very little in Latin and South America, with the exception of what I'm about to talk about. So before I get there are a lot of really extreme emotional ties to food in Latin and South America. And there are some quotes like, "The sorrows with bread hurt less, and a full belly is a pleased heart," which really illustrates how emotional ties can affect the perceptions of certain cultures to food, which is probably why a lot of researchers believe that bulimia and binge eating disorder are more prevalent in Latin and South America than the United States or the UK or Asia, because they don't have those emotional ties that some places in Latin and South America do. However, that said, there are also fashion capitals of the world in Latin and South America, like Medellin, Colombia, and in Argentina. 18% of adolescent females, which is the highest number in the world, suffer from eating disorders, particularly anorexia, because of it being a fashion capital. And between the years of 2005 and 2007, those numbers rose 115% in adolescents, 10 to 19 in Chile. So it's extremely, it's the most westernized part in that city, in Medellin, Colombia. And so the sorrows with bread hurt less doesn't really apply there. The quote, "Nothing tastes as good as thin feels," popped up, which first of all is untrue, but second of all, the belief there holds pretty strongly, especially backed by those statistics. So you can have a continent that has massive divide because of two different cultural norms happening in the same place virtually. So they actually have a fairly comprehensive NGO called ALUBA, La Asociación de Lucha contra Bulimia y Anorexia, founded by Dr. Mabel B. Bello in 1985, which operates in Argentina and Uruguay. And it has one of the highest recovery rates post-treatment but it also has one of the highest problem rates of eating disorders in the world. So that's very interesting, possibly because they do such early intervention, because this part of the world is so heavily into generational eating disorders, because a lot of the parents, mom has an eating disorder, dad has an eating disorder, all the kids have eating disorders. But then they intervene early because children all have eating disorders. So this Aluba takes children very young and treats them. So that's possibly why they have one of the best recovery rates. So they do a lot of teaching and research departments and have some of the best treatment in the world that is all up to date. They do refresher courses with the latest information and education for different healthcare specialists at their institution, and provide education to the parents and the children about eating disorders through treatment classes and seminars. They have 3 different tiers of treatment at Aluba as well. They have a hospital with self-help groups, daily nutrition management, family therapy, family psychotherapy, clinical evaluation, and psychiatric evaluation. The external group is basically like the day hospital, except it's 3 times a week for 90 minutes in each session, when they have mild symptomology present. And then the child care, they take children up to the age of 12, and they can start as early as 4 years old. They have had children who are displaying very significant eating disorder symptoms when they are 4 years old. And so they take them and they start treating them, and then they have much better outcomes because they have started when they are so young.
There's a question of the affordability of these treatments in Latin America versus in the United States. Is there more access, or is it more affordable there?
Honestly, I am not positive how accessible it is price-wise. There was not a ton of information about that. That it appeared that a lot of it is funded through the government. So it's more of when it is necessary, it gets paid for, rather than it has to come out of the family's pocket.
A little more universal coverage being paid for by the government when you meet criteria versus do you have insurance or not?
Correct.
Got it.
So due to the crisis that was happening in Medellin, Colombia, a Dr. Lucrecia Ramirez Restrepo created a network for the prevention of anorexia and bulimia and launched Project Skinny, which featured the slogan of "Skinny Pretty Happy" in order to challenge the belief that she encountered with pretty much everyone she was meeting, even on the street, that basically thinness equaled beauty and happiness. So this billboard says, "It looks weird, right? And you, how do you look?" Obviously, this wouldn't particularly work in the US because honestly, a lot of people don't even know how elephants are supposed to look. But this elephant is, for lack of better terminology, an anorexic elephant. This elephant does not look the appropriate shape, weight, or anything else. So for someone coming from this part of the world, they would be able to look at this elephant and go, "Oh man, this elephant is sick. Someone needs to help the elephant." That would make someone pause and go, "Huh, how do I look?" So that really had an effect from a social media standpoint, because we all know, we see the billboards, we see the commercials on TV, but if we, had an equalizer like that in the US, this was their equalizer in Latin America. Seeing this made people stop and think, what were they actually doing? What were they actually participating in? So then moving on to Japan. Japan is a very interesting place with Asian culture. So eating disorders are extremely underreported in Japan, but the most current data we have suggests that at least an absolute minimum of 3%, or roughly 3.8 million people, suffer from eating disorders, specifically anorexia or bulimia, in Japan. The law I was referring to before is called the Abel Law. So people between the ages of 40 to 75 years old must measure, for men, a waist of 33.5 inches or less, and women's waists must be 35.4 inches or less. If these guidelines are not met when you are measured, Within 6 months of a diet you must follow, along with governmental re-education, financial penalties will be imposed on the company you work for, along with shame to you and your family and your company, because it will publicly be known that you did not meet these, which is hard to wrap your brain around if you can think about standing in a line, waiting to be measured, and then have it announced to the world that you don't meet this standard. As of November 2017, 11.6% of adult women ages 20 or older were underweight, clinically underweight, of a BMI of 18.5, which is significant for anorexia nervosa. And that, for Japan's population in 2017, is 14,708,800 women underreporting. So there's going to be more than that, and that's just the ones that we know about. So one of the issues with Japan is that it's very culturally homogenous, and it's not a melting pot like the United States. Everyone wants to look like everyone else. They feel compelled to dye their hair black if it's not black enough. They want to be just as thin as everyone else. Women were reporting to their doctors, even if they knew it wasn't healthy to not get their period, but if they were still not thin enough, they would still try to lose more weight. Around 30 to 40% of women said they were eating less than 1,200 calories a day regularly. That's not enough even for your brain to function if you didn't even get off the couch all day. It's very a for country, for family, for community, for the betterment of everyone type culture, versus the United States, like me, my, mine, self-driven kind of culture. They're a very community-driven culture, just like for the honor of everyone. So like an example of that is, in their schools, they do not employ janitors. They expect the children to clean up their own schools. They don't employ janitors. You want to clean school, you clean it up. You want to clean bathroom, you clean it up. They're very much, we take care of ourselves, we take care of our honor, our family, our community, our culture. So they want to be just like everyone else. And that's part of it, is they value this small, tiny, beautiful type image, and they will just do about anything to keep that image going, whether it's damaging their health or not. So unlike some of these other NGOs, the NGO in Japan is in its infancy. It was only introduced in June of 2018. And it is currently funded by one man. His last name is Miwara. So the Miwara Hoi Ai Fund supports this effort currently, and is backed by the Ehime Eating Disorder Support Organization in Matsumaya City, Osaka. And the campaign that they started is called the Magenta Ribbon Campaign. And if you think about like yellow ribbons for childhood cancer, it's basically like that, except for eating disorders in Japan. So what these people started is these magenta ribbons, and they have a little ribbon, and it's a pin, and then on the back it has information and some resources about eating disorders. And they've started putting them in medical offices, government, educational places, on like pin boards in the community, and handing them out to people. And what they're trying to do is spread awareness, because people a lot of times don't even realize they have an eating disorder, because it's just what people do. My mom does it, my aunt does it, my 3 friends do it. It's just what we do in order to uphold this image. So the researchers are trying to spread awareness and trying to educate everyone so that they can actually get information out there and get help to people, because Japan is currently, of all the countries I researched, the only place that has no mental health clinics or hospitals for eating disorders, because they simply do not have enough resources or enough belief that it is a problem in their community. So there are simply no resources for people who currently suffer. So those are all the countries I did. And then the population, the vulnerable population that I did, was the LGBTQIA community, because they have a staggering number of eating disorders in this community. And a huge number of males who identify in the LGBTQ plus community have eating disorders. 42% identify as gay who have eating disorders. And in a strictly US study, 1,034 young people who identified as LGBTQ plus, over half of them had been diagnosed with an eating disorder between the ages of 13 to 24. Of the 46% who had not been diagnosed, all of them reported suspecting at some point that they had an undiagnosed eating disorder. Literally all of them had. So that is really telling that this is not just about food. This is really about control and trying to figure out how to help someone who has issues that we don't know about. And this is way more about this is way more than about food, which a lot of times people say, well, it's this person is exercising and not eating, it has to be about food. Really is not. Those are the things you can see. It's about so much more than that. So at some point, all of these people had suffered with some sort of disordered eating or been diagnosed with some sort of eating disorder. And unfortunately as well, the report found a strong tie between eating disorders and suicidality, and 96% of those diagnosed with bulimia had considered suicide, and 66% had considered suicide and had been diagnosed with an eating disorder. So there's a really strong tie between eating disorders, suicidality, and the LGBTQ plus community. So these are people who we really need to make sure have resources, are educated, and we are catering to in a way that they have information so that this does not happen, that they are not left in the dark without resources. So the NGO Project Trevor is amazing with the LGBTQ plus community. They have Trevor Lifeline, Trevor Text, Trevor Chat, Trevor Space, and Suicide Prevention General Info at their website. It's located in West Hollywood, California, and it's the leading national organization for crisis prevention, suicide prevention, and LGBTQ plus youth. Fantastic resources. They can be reached day or night, 24/7, and they have really amazing different support groups and information for this population to help them get the support they need to try to alleviate some of these burdens that they face in figuring out how to function in our society. And then Project Trevor is also funded by lots of small NGOs, funded by other NGOs who care about this population, who are really trying to bring the best care to the LGBTQ plus community, all through other small NGOs, because the government really stays out of this, just like in the rest of the NGOs I've spoken about with the US, because they really don't put their hand in any of this. So another huge part of the research I did was nursing considerations with eating disorders as biological illnesses, because one of the myths that I debunked was that eating disorders are a choice, and they are absolutely 100% not. And in the recent years, they have been linked as biological illnesses, and a lot of genetic components have been uncovered, and a lot of studies have been done that are really cool. So one of the first studies to be done was in 2002 for a possible genetic link to anorexia nervosa, and it was found that on chromosome 1, there was a genetic link for individuals with 2 separate DNA sequences close together, supplying biological evidence for a genetic trait, which was absolutely huge when that was discovered. And over the last 10 years, 10 more genes have been discovered linking genetic variations to individuals suffering from anorexia nervosa.
Lucy, you're having a couple students who are noticing a lot of similarities between eating disorders and drug addiction or addictive behaviors.
Yes, there are huge similarities between those. There's a lot of research being done currently between eating disorders, which they are addictions. They cross a lot of the same brain pathways, and there's a lot of addiction within eating disorder. The same behaviors, binge purge is an addiction, excessive exercise is an addiction, taking laxatives is an addiction. All of those things are addictive behaviors. Fasting is an addiction. All of those things are addictions within the disorder. And I'm sure I'm missing tons.
Yeah.
So
in the group chat, people mentioned, we're asking about smoking and eating disorders, and there was a little conversation about the fact that nicotine is a central nervous system stimulant and actually causes appetite suppression, and is very commonly seen as an addiction in individuals with eating disorders for multiple reasons.
Yes. People will smoke a lot. People who've never smoked a day in their life will smoke if they have an eating disorder to suppress appetite. It's not uncommon at all to see. It crosses so many of those same pathways, which a lot of this evidence uncovers that a lot of these pathways are linked in ways people never knew about. So yes, very astute observation. So on chromosome 1, they were able to discover that the disturbed sequence for anorexia codes for a protein that responds to serotonin. Serotonin, as we know, affects mood, opioid receptors, and appetite, which explains distorted body image, changing moods, and starvation seen in anorexia, and how this then is truly a biopsychosocial illness. So the swinging door then is, which comes first, part of the problem with starvation and anorexia, or the anorexia and the starvation? That's the problem. This is a circle that we get stuck in then for people with anorexia nervosa, because symptoms of starvation are also symptoms of anorexia, and symptoms of anorexia are symptoms of starvation. So you fix one problem, you still have the other problem. You fix the other problem, you still have the second problem. So part of this is enormous, because they did a study. The ethicalness of this study is up in the air, but they took men through military service in the United States. I believe it was in the 50s and 60s, and they starved them, and then they refed them. They showed a lot of symptoms of anorexia nervosa. They didn't have anorexia nervosa, but they had those symptoms because those symptoms are those of starvation. So it's very interesting because it's a biological response to starvation as well. So
I think I'm trying to understand this a little bit as well. What you're saying basically is that individuals who have been starved show signs of anorexia when they're not anorexic, and individuals with anorexia obviously show symptoms of starvation because they're starving themselves. And we don't really know what comes first.
Yes, because the symptoms of starvation, like being absolutely obsessed with food, not being able to think of anything else but food, planning out your day around food, then not being able to choose what food to eat, things like that, those are symptoms of starvation. Eating too much, getting sick, not being able to eat again, all these things, these happen to these men who were starved. They did not have anorexia nervosa. They were starving to death.
Got it. Yeah, and there's a very astute comment in the chat as well that yes, that study would not fly in modern times, hopefully.
Yes. It did provide a lot of interesting data. So the absolutely most powerful and groundbreaking study done to date was by the University of North Carolina in 2017. It was discovered that part of chromosome 12 that houses genetic variations for anorexia nervosa, type 1 diabetes, and autoimmune diseases. So this is a genetic locus that was pinpointed for all of these diseases. Anorexia is significantly genetically linked to neuroticism, schizophrenia, and high education attainment. So this makes perfect sense then, because it's linked to high education achievement. You've all heard, the overachiever, the perfectionist. You're slightly neurotic a little bit. Yep. Schizophrenia. Are necessarily people with anorexia nervosa schizophrenic? Absolutely not. but it's in that same realm with mental illness. In those pathways, a lot of other problems occur. So being able to pinpoint this genetic locus with all these other problems, a lot of people with anorexia nervosa have other autoimmune diseases. Type 1 diabetes is an autoimmune disease. Lots of other autoimmune diseases are associated with the same problem on that genetic locus, which really explains a lot of research that they had done, and then being able to pinpoint it allows them much better ways in the future to help people with this disease. And then in 2019, research were able to confirm through replicated studies that genes are at least 60% responsible for the occurrence of anorexia nervosa, which is so huge, because for the individuals suffering from this disease that have had people tell them this is a choice, a lot of people have said that, you know, people who develop this disease are dumb. Why are they choosing this? Why would you live your life like this? This is not something that is a choice. This is not a lifestyle choice. This is not something they're doing in spite of someone or something. This is massively biologically related as well as psychologically and socially. So this was a huge breakthrough to be able to prove this and have research to back it up. So unfortunately, we're still having a lot of poor outcomes, and you'd think with all this research, we wouldn't be. So why is that? Well, unfortunately, like I've talked about, this disorder is extremely complicated, and it is biopsychosocial. And yes, we have care models for that, but the cognitive, psychological, metabolic, neurologic, environmental, and different continents we're working with, one global care model just doesn't work. You absolutely cannot take one model and go, oh, that's going to work, because it won't. There cannot be one treatment protocol to address this. This is going to take time, effort, and a whole lot of smart people to come up with different holistic care models for different countries, different populations, and every single person is going to need a different approach, quite honestly, because you can take two people from the same country, from the same city, with the same disease, and have the same approach not work for them. So that's the reason why we're still having such poor outcomes, because one size does not fit all for this disease. In addition, if you look at these two brains, the left is a healthy brain, and on the right is the brain of an individual with anorexia. I circled a portion of this scan. As you can see, the scan of the individual with anorexia does not look like the scan of the healthy brain. So there's a portion missing from the scan of the individual with anorexia, and that is the prefrontal cortex. And if you guys remember anything from A&P, the prefrontal cortex is pretty important. A bunch of stuff to do with planning, complex thinking, behavior, judgment, personality, expression, decision-making, and social behavior. So if you take all of those components and you take someone that's been starving themselves or binging and purging, not getting the proper nutrition, and you ask them to plan, complexly think, judge things, have the personality, honestly, socially behave, and make complex decisions, they're going to be incapable of doing that. They probably cannot even pick out their outfit, to be perfectly honest. And if you imagine that part of your brain not working, how could you honestly interact with the world or make life and death choices for yourself? So it's not that these people are not making these choices on purpose for themselves, it's that they just can't. That part of their brain isn't functioning. So we have to be cognizant of the fact that there have to be different layers of treatment, and you have to medically and nutritionally stabilize someone, because there are very few people who are absolutely incapable of recovery, but the system is creating people who are incapable of recovery by not appropriately treating them and treating the different levels that they need in order to create individuals who are capable of recovery.
Lucy, there was a point that was made in the chat that mentioned it must be hard for someone without a strong prefrontal cortex to even recognize that they need treatment or have a problem.
Yes. If it is not addressed that someone does not have this problem, of lacking judgment in a prefrontal cortex, they can be labeled as non-compliant. They can be taken to court and forced into treatment. They will ultimately fail because they don't even realize they need help is the problem. They might eventually, if people don't give up on them, because eventually if you nutritionally stabilize a person, they will realize with nutritional stabilization of the brain that they can get better. But you have to be a minimum of 85% of your ideal body weight before that can happen. So if you have someone who is critically underweight, they cannot even attempt to understand that they need help before they are 85% of their ideal body weight, because that is when brain restoration can happen.
So really it's nutrition that's affecting their brain function is what you're saying. And so once we get these people adequate nutrition, then we can start with the behavioral and cognitive therapies that will actually deal with the impaired thought processes that lead to eating disorders.
Yes.
And then there was a question of if the brain scans here, is this something that occurs after the disease starts, or are they born with their brains like this?
This is after the disease starts.
So it's usually related to malnutrition that their brain looks this way, they're finding.
Yep.
So it's someone with anorexia nervosa's brain looks similar to someone who's malnourished for non-eating disorder reasons.
Mm-hmm. So then we do have some US government involvement. President Obama in 2016, at the very end of 2016, signed the 21st Century Cares Act, which was the first piece of federal legislation to mention eating disorders specifically ever in the history of the world. The end of 2016, guys, that was very recently. So yay, but oh my gosh, it took long enough. So it makes access to treatment easier, affords insurance companies less flexibility to deny coverage, and it aims to better educate the healthcare professionals and the public at earlier detection of eating disorders. And it tries to study how early intervention leads to better long-term outcomes. And this actually is the result of the Anna Weston Act, which is what I'm going to talk about now. So the Anna Weston Act of 2015 is the reason that the 21st Century Cares Act ended up being pushed through. So Anna Weston was a Minnesota teenager, and she had anorexia nervosa at the typical time, around 15 years old. She went to treatment, she got better. She went to college. College is a huge trigger for a lot of adolescents who recovered from eating disorders. When she was a sophomore in college, she had a very stressful time in her life. She relapsed, and unfortunately, her parents went through a lot of financial difficulties. Her insurance would not pay for treatment adequately. She felt like a terrible burden to her family, and she was extremely sick. And in February of 2000, she died by suicide. Anna Weston's parents sued Blue Cross of Minnesota for improper coverage of care for their daughter. It took 15 years. They fought in court against Blue Cross of Minnesota from 2000 to 2015 for a wrongful death lawsuit and won $8.2 million settlement for their daughter. They did not give up and live a comfy lifestyle after that. They have every single day for 15 years of that time, and every single day since, gotten up to raise awareness of eating disorders. They used that money and created the Anna Weston House, which was the first in-state residential eating disorder treatment facility for Minnesota. And it is now part of the Emily program, which is a residential and inpatient treatment facility in Minnesota. This act aims to educate and increase professional awareness inform school curriculums, and provide coverage for treatment and make it more accessible for everyone. And if you have Blue Cross insurance in Minnesota, you absolutely cannot be denied coverage for your eating disorder. If you have an eating disorder and you live in Minnesota and you have Blue Cross insurance, you will be getting eating disorder treatment because of the work that they did. So basically, big picture, I was able to interview professionals who work in the field, dietitians and therapists, and basically this is what they said about what needs to change for eating disorders for nurses for treatment and education. Every nurse needs exposure to eating disorder education and training. The diseases are growing at an exponential rate, and the care required is totally manageable, but it involves specific care in order to reduce harm long-term to patients. Super easy to evaluate a patient's physical health, and if you just ask a quick couple of questions for a mental health check-in about eating habits, you can save someone years of suffering. So if you check in with your patient about new diets, if they're labeling foods good and bad, cutting out food groups randomly, having any kind of body distortion, fixating on imperfections, if they're having random control issues in parts of their lives, it's going to change. Those mental things are going to change way sooner than having vital signs that are off, labs that are off, before their weight drops off. That's going to save someone years of misery if you just stop and check in with them about those things and maybe have those resources for them to be able to refer them to a good eating disorder therapist. And as just a general rule from one of the amazing dietitians I talked to, stop labeling foods good, bad, healthy, and unhealthy. There's absolutely no such things. And by us labeling them, those good, bad, healthy, and unhealthy, we're really perpetuating the disordered perception of food in our society. And this dietitian said to me, you know, toddlers really know how to eat. Toddlers eat when they're hungry, they stop when they're full, and they drink a lot of water. So if we would just all eat like toddlers, we'd be way better off. So moderation is the key, and everybody should eat like a toddler. So our needs as one global community really are that increased funding for NGOs would help us really a lot for funding for research. And being able to promote more direct government involvement and have public health education and initiatives in order to continue to decrease the stigma and raise awareness would be really great, because we know, like right now we're in the middle of a pandemic. Well, eating disorders are also a pandemic that have been going on for a really long time. They've been eating disorders diagnosed in the 1700s, the first one. It's been forever now, and just because you can't catch it doesn't mean it's not a problem. So we know what works. The CDC needs to be involved, you know, put commercials on TV, put up billboards. Let's get some people moving in the right direction here. Let's address this so that we don't have another generation of little girls and little boys in fourth grade classrooms wondering if they need to eat their sandwich at lunch or wondering if they should run some laps. You know, it's a really big problem, and we definitely have the power to change it, and we have the power to change the narrative. So we really need to do that. And if we were able to have, you know, in 50 or 100 years, targeted gene therapy, because people have no control over what biology they're born with, but maybe we have the power to change some of that. And we do need a lot more research before that's possible. But if we have the funding, we could possibly make that research possible. And improving the accessibility to treatment is also a big problem right now, and that needs to be addressed as well. So those are basically the big things we need to do as our global community. And the last thing I want to do is close with a poem as well. And this basically wraps everything up together about how someone can recover from an eating disorder as well, and ties everything in. So, dear little curious one, you came into this world unknown, with thoughts and feelings all your own. An inquisitive one from the start, you fought for others with all your heart. One day at 6 years old, your world crashed down, leaving you scared and your world mysterious. I'm so sorry, little one, that you could no longer be curious. Dear little scared one, you try so hard to just be perfect and keep the peace. Your broken soul was desperate to find some release. The day she came knocking was an innocent one. I'm so sorry you had no idea the torture had not even begun. Dear little trapped one, control she promised, perfection and beauty, safety, security, numbness and purity. Lies, loneliness, and shame she delivered. I'm so sorry for perpetuating the insurmountable pain. Dear little starving one, you shiver and shake, your body literally aches. You wish you could just stop, but her voice so loud and foreboding, it makes your heart drop. She hijacks your wishes and crushes them with an iron fist. You are now officially anorexia's marionette. Not even a glimpse of your once inquisitive self will you ever get. I'm so sorry I invited her in, it's all my fault. Dear little starving one, she's ledged a full-fledged assault. Dear little hopeless one, it's been 10 years since diagnosis now. Your body and soul are done fighting somehow. You can't keep on going like this, you can't live with the distress. You wish every day for your mind and body to be laid to rest. The hands of death came for your friends and took them one by one. Her cold indifference shirked your weak attempt to fight. Your time here is done. I'm so sorry I didn't fight harder to help you know. The world needs you to be and learn, live and grow. Dear little brave one, you're a fighter, that's for sure. I'm so sorry I loved everyone but you, and yet you endured. You built your strength from the ground up, rebuilding your foundation to prevent further disrupt. Over and over, with no permanent retreat, you picked yourself up and refused to be beat. Your soul is still mending the holes that it has, but oh my dear little brave one, what a strong life you've had. You continue the fight for every lost friend. The road is bumpy and the journey doesn't end. Choosing recovery with purpose and design. Oh, little one, I am so proud of your genuine shine. And that's the end of the presentation.
Wow, Lucy, that was amazing. Are there any questions that anyone has before we finish up the recording? Feel free to unmute your mic if you have a question. You're getting a lot of great jobs in the chat, Lucy. Apparently we've got criers in the mix. People are glad they weren't wearing mascara.
Thanks, guys.